Welcome to the deep dive. Today we're getting into something that is, well, it's the absolute foundation of emergency medicine practice here in the NHS.
It really is.
We're going to be drilling down into the blueprint for safe and effective practice. Specialty Learning Outcome 1, SLO1.
And this isn't just, another item on a checklist. It is the absolute bedrock of the entire curriculum.
We're talking about care for physiologically stable adult patients presenting to acute care across the full range of complexity.
Exactly. And if you can't master SLO1, you really can't be an emergency medicine consultant. It's that fundamental.
That phrase, full range of complexity, that's doing some serious heavy lifting, isn't it?
It is, because the whole point of the RCEM curriculum is to train consultants who can handle any undifferentiated patient who walks through the door.
Especially with the increasing numbers of older patients with really complex comorbidities that we see every single day.
And what's fascinating here and what we want to get into is that mastering SLO1 is about more than just clinical knowledge. It's about expertise in that whole encounter.
So history taking, examination.
All of it. History, accurate examination, complex decision-making, ethical management.
Right.
So our mission today is to unpack what that mastery actually looks like and, crucially, how you can evidence it through your training.
Okay, so let's start with that definition of complexity. The curriculum is actually quite explicit about three patient groups that, well, they dominate our workload.
They do.
It specifically requires a deep aptitude in caring for patients with mental health problems, patients with complex comorbidities, and critically, patients with frailty needs.
And that's almost every challenging case in the ED, right? And the curriculum is very clear that your capability has to grow progressively. It's all framed around increasing levels of entrustment.
So let's break that down. If you're at the ACCS or core level, what are the expectations there? You're still under direct supervision.
At core, yes, you're functioning with direct supervision right there. Your goal is to manage, let's say, uncomplicated complexity.
What does that mean in practice?
It means identifying the need for social input, knowing the key legal frameworks, and importantly, formulating management plans that genuinely prioritize patient choice.
So that safety net is available right at the bedside.
It is. But then you make the jump to intermediate training.
And that jump feels massive. I mean, your supervision suddenly shifts to being on call from home. How does the curriculum make sure that's safe?
That's a great question, because the shift isn't just geographical, it's cognitive. At intermediate, you're expected to assess and manage all adult stable patients.
All of them.
And handle that high-risk complexity like patients with multiple interacting conditions or serious polypharmacy before you escalate. You should be able to formulate those plans with confidence, knowing your senior is a call away.
But they're not necessarily at the bedside anymore.
Exactly. And then finally, you get to higher specialty training.
And at that point, you're expected to be the expert.
You are. By higher training, you should be able to manage with no supervisor involvement and actually act as a role model. It requires real expertise in balancing that shared decision-making with risk in these highly complex patients.
And to get there, the descriptors for mastery are incredibly specific. In core clinical skills, for instance, they really emphasize that shared decision-making and appropriate investigation selection.
Absolutely. And for those complex groups, it gets even more specific. For mental health, it demands a competent assessment of suicide risk, compassionate management of disturbed behavior.
And a solid grasp of the legal frameworks, which is often a huge area of uncertainty. Things like safeguarding, capacity.
It is. And then you look at our older patients, and SLO1 demands we go beyond just treating the initial complaint.
We all know the pitfalls there. A 90-year-old with a supposedly simple fall.
Right. And SLO1 says you have to go beyond that initial trauma assessment. You have to actively screen for the frailty syndromes, falls, delirium, polypharmacy. You have to recognize those physiological pitfalls.
Now, let's pivot to the practical core of all this. The consultation itself. Pendleton called it the central act of medicine.
He did, and you just can't master SLO1 without mastering the consultation. It's a learnable, structured skill.
So models like Pendleton's.
Pendleton's model breaks it down into 7 tasks, but it's heavily focused on the patient's perspective, defining why they're there by using IC ideas, concerns, and expectations.
And achieving that shared understanding. It's data gathering and connection at the same time.
Precisely. And the Calgary-Cambridge Guide gives you that structural framework, the 5 stages: initiating, gathering info, building the relationship, explaining and planning, and closing.
But here's where the source material gets really interesting, I think. Nonverbal communication.
Yes, this is crucial. Our sources stress that our nonverbal messages, They often say more than our words.
And if they conflict, the nonverbal one wins. Every time.
Every single time.
The link they draw between a doctor's tone of voice and things like patient satisfaction and even malpractice claim history, that's just stunning.
It is. Because a hurried tone or, defensive posture, it signals a lack of respect. And when patients feel heard, they're much more forgiving of a bad outcome.
Which brings us to a huge practical challenge in every ED right now.
Yeah.
The computer, the electronic health record. We are forced to look at a screen instead of the patient.
We have to actively mitigate that. The recommendations are actually very clear and very practical. First, postpone.
Postpone.
Deliberately delay using the computer. Don't touch it until the patient has completely finished their opening statement. Give them your undivided attention.
Listen first, type second.
Exactly. Second, wait. Use those little moments, when the patient is pausing to think, to glance at the screen.
Opportunistic typing.
Right. And third, and this is so important, signpost. Verbally tell the patient, okay, I'm just going to look at your records now, and then, right, I'm finished with that, so they don't feel ignored.
Moving on from the consultation, SLO1 also requires accurate clinical examination, but grounded in evidence, moving away from just rote performance.
Absolutely.
Yeah.
And trainees should be using resources that ground their physical exam findings in actual diagnostic probability.
Things like the JAMA Rational Clinical Examination Series.
Exactly that. It gives you the likelihood ratios you need to actually trust your exam findings.
And I've seen the Stanford 25 resource mentioned too. That's more than just a checklist, isn't it? It's high-quality video instruction.
It is. It helps you refine the specific findings that textbooks often just gloss over. It's all about moving toward a really specific, evidence-based physical diagnosis.
So once you've mastered the consultation and the exam, the final hurdle before sending someone home is, well, it's ensuring that mastery translates into safety.
And that means rigorous safety netting. It's a critical skill. It really comes down to asking and answering 3 core questions. 1, what do I expect to happen if I'm right about this?
Okay.
2, how will I know if I'm wrong? What are the specific red flags? And 3, what would I do then?
And the answers to those questions become the advice you give the patient.
That's the clear, actionable advice they take home with them.
That focus on complexity also forces us to shift how we think about diverse populations. The sources are clear. We have to move beyond just cultural competency.
Yes, that's a key paradigm shift. The problem with competency is that just learning facts about cultures can sometimes lead to stereotyping. The new model is cultural safety.
And the main focus there is the power imbalance.
It's all about the power imbalance between the clinician, who holds all this institutional power, and the patient. It requires you, the clinician, to reflect on your own biases and privileges.
And the most important part, the patient defines the outcome. The clinician doesn't decide if the encounter was safe.
The patient decides. And the stakes are incredibly high. The source material gives a case where a provider's bias, stereotyping a Hispanic female patient as histrionic,
Could lead to them missing an acute coronary syndrome and calling it anxiety.
catastrophic. Our biases can, and they absolutely do, influence our clinical reasoning.
So to combat this, there's the reflex mnemonic. It's a really tangible tool. Can you walk us through it?
Of course. So R is for recognize the power imbalances. You're in the dominant position just by being the doctor.
Okay.
E is for examine your own biases. You have to actively confront your assumptions before you even start talking to the patient.
Then F for foster trust and L for any sound. Listen and validate their experience.
Yes, don't just dismiss their story if it doesn't fit your textbook picture. And then the next one is crucial. Empower the patient to define what makes them feel safe. That gives them back some agency.
And the last 2 are about systemic action. Critically self-assess and take action to challenge inequities in the system itself.
It moves safety beyond just your consultation. And there are practical steps, using professional interpreters, respecting gender preferences for providers, and using validated tools like the 4AT score for delirium instead of just your gut feeling.
So we have the skills, the consultation, the complexity, the cultural context. The final piece of the puzzle is evidencing all this. How do you prove it?
Right. You need a really robust portfolio of your workplace-based assessments, your WPBAs, and you need to be seeking feedback regularly, especially on those difficult cases.
So which WPBAs are we talking about for SLO1?
You're looking at your AC kits, case-based discussions, your CBDs, mini CEXs, multi-source feedback, and a good logbook. CBDs are particularly good for showing your reasoning in these complex, stable patients.
And all of that feeds into the final entrustment decisions. So let's look at those levels. What does level 2B mean at the end of core training?
Level 2B means you're entrusted to evaluate a stable patient and formulate a differential diagnosis that explicitly includes the worst-case scenario. You know what might kill them.
But you're still under direct supervision for the final plan.
Exactly. You can interpret an ECG and X-ray, but you know their limits and you know when to escalate.
And how does level 3 at the end of intermediate training build on that?
The big change at level 3 is that you're now entrusted to evaluate any physiologically stable patient and formulate a safe management plan in all but the most complex, uncertain cases. You're showing high reliability with remote support.
Which brings us to the end goal. Level 4 at the end of higher training.
And level 4 is independent expert practice. You're entrusted to evaluate any stable patient, formulate the expert plan, and you're now a role model, teaching others how to manage this complexity. You are the supervisor.
So to pull this all together, SLO1 is so much more than just a basic history and exam. It's this comprehensive expertise needed to handle all kinds of complexity, from frailty to mental health to cultural barriers.
It is. And what's really fascinating is that your ability to get to that final level 4 entrustment is directly linked not just to your clinical knowledge, but to those non-clinical skills. Specifically, your capacity for critical self-reflection on your own biases.
That synthesis of soft and hard skills is what marks an expert.
That's it exactly.
An incredibly important point. Thank you for walking us through this. And for you, the listener, here's a thought to carry into your next shift. Given that SLO1 requires you to handle the full range of complexity, think about the last time you managed a frail older patient. How often did you let a simple initial diagnosis override the complex social and frailty needs of that person? Were you truly addressing the full range of their complexity?